I'll watch the Q&A in the chat for you.
Good afternoon, everybody, or good morning, wherever you may be in the world. I'm Debbie Plotnick. I'm Vice President for Federal and State Advocacy at Mental Health America, and Mental Health America is the US's oldest mental health advocacy organization. And one of our priorities is to work with people who find themselves engaged, usually not by their own volition, with the criminal justice system. So it's a particular interest of ours. We're really happy to have such experts with us today. We have Maria Leggio, who is an associate professor of social work at York University in Toronto, Canada. And she is currently working on the experiences of psychiatric children and youth and their caregivers with crisis response. And we're going to hear from Maria last. And in between, we're going to hear from Naomi Zakoni. And Naomi's a PhD student at Simon Fraser University, also in Canada. And her research is understanding how criminal, human, and social capital are related to criminal achievement. We're going to begin with a video from one of our speakers who was unable to join us. Ashley Stewart is a student at Burnet Institute in Australia, and the time difference made it difficult for Ashley to be with us today. And she's working on the prison and transition to a healthy cohort study, and she's focusing on mental health service access among people who are involved in the criminal justice system. So I'm going to share my screen and I'm going to play Ashley's video. Let's see if we have it right here. And if I can start playing it, let's see if that works. How do I get that?
Hi everyone, my name is
over there?
As part of the behaviors and health risks.
You have to share screen now?
Yep, I thought I was, but let's try it again. Share screen, screen one.
There we go.
Okay, excellent. Thank you everyone for bearing with me.
Mental health contacts in the year prior to first adult imprisonment and men with a history of injecting drug use in Australia. Firstly, I would like to acknowledge the
Debbie, you may have to click on the sound button at the bottom of the share screen.
Can
where
you
it
see
says,
the video, Richard? Can everyone see it?
I think we can see it. We just
Couldn't hear it? Okay.
yeah, so click on the share sound and optimize for video clip in the bottom.
Bear with me. I apologize, folks. This was sent late last night and we didn't have a chance to figure out a platform we'd never seen before.
You see the two boxes at the bottom of the share screen. When you click on the share screen at the bottom, should be one that says share sound and another that says optimize for video clip.
I apologize. I am trying to get back to where we were, where I could see all of you and I could see that full screen. I'm not able to see that full screen at the moment.
Okay, just hang on a second here.
I apologize. I am unable to make this work at the moment.
How about we go to someone else and then
Exactly what I was going to suggest. Yeah. Naomi, you're up. Naomi, you're muted.
Sorry, it won't let me share my screen unless you stop sharing yours, Debbie.
Okay, I apologize. I am trying very hard to get this back, and I don't seem to be able to.
Debbie, there should be a bar at the top or at the bar. Sometimes the bar is at the bottom, and it will say end share screen. We'll give you the option to end it.
I can't get this screen to say that. I know where it is. I can't get this to open. There we
Oh,
go.
there.
Okay, I closed
Now
it.
I
Yeah,
got
I'm gonna try it. Yeah, I'm gonna try it here now.
Thank you. When I started sharing, it wouldn't let me come back.
Oops. All right, now I think I messed myself up, so we'll be okay. Just hang on.
Joys of virtual conferences. So thank you to all of our participants. We really appreciate your patience.
That should, now you should try it again, Naomi, and hopefully it'll
Okay.
work.
Let me see. Okay. Can you see my presentation?
Can.
We can. We're all good.
Perfect. Great. Awesome. Thank you. Okay, so today I'll be presenting on a research study that we've been working on with Dr. Alyssa Greer for the past almost year. And our study is called Too Many Hats, exploring the public health and social support roles of police officers in British Columbia, Canada. So I'll briefly mention what I'll go over today. We don't have much time, so if you have any questions at the end, I'm always happy to chat. But I'll tell you what my research question was, the data and methods, then I'll go into the findings in a bit more detail, and then I'll conclude. So our guiding research question was we wanted to look at how police officers in BC viewed their role in providing public health and social support to people who use drugs. And in that, we were really interested in seeing how police thought of their current role, so what they were actually doing, and what they thought they should be doing. So in order to do that, we interviewed 16 police officers. We conducted semi-structured phone interviews with officers across BC, so officers who were working in big cities, and also officers working in more remote, smaller communities. We used a combination of snowball and purposeful sampling and thematic analysis to analyze the interview transcripts. And we concurrently collected data and analyzed throughout the whole process. So I'll jump straight into my findings because I think that's the most interesting part. So we found two main themes. The first theme that we found, we discussed the multiple roles and conflicting roles of police officers. And in the second theme, we found a lot about how police officers think about alleviating and addressing role strain and the frustration caused by the different roles that they're compelled to play. So I'll go over some of the roles, the four main roles that we found police officers talked about, or the different hats, as we call them in our paper. So the first two roles are not that surprising, but they are interesting in that they compete for attention with the other two roles that I'll discuss in the next slide. So all police officers viewed their role as law enforcers. So to different degrees, they thought that their main job was to enforce the law. Some of them thought that was their main role. Others thought that perhaps it wasn't as important, but they all considered it to be part of their job. The paper pusher role, and by the way, sorry, I should have mentioned, these are quotes taken from our interviews to exemplify some of the ways in which police officers talked about these roles and highlighting the strain and the frustration that performing these roles caused them. So for the paper pusher role, it's well known that police spend a lot of time in the office doing paperwork, and in our case, the police officers that we talked to were very frustrated with how long it took them to build strong cases, to collect evidence, and then the time that they spent in the office actually writing all of these reports and communicating with people in the criminal justice system. So they felt that this role especially took away from the roles that they wanted to be doing, which were more hands-on, so were things like law enforcing, helping people, and building relationships with the community. So the next hat or role that we found and that we thought was very interesting was the helper hat. So many of our officers spend time out in the community helping people. And for a lot of them, this was a crucial part of their role. And especially when it came to interacting with people who use drugs, which all of our officers did to different extents. They all felt that they had a role to play in helping people with things like, for example, harm reduction. Not all of them agreed that that this was something that they had to do, but they were all doing it to different extents because they were compelled or they were forced to fill a gap in services in the communities in which they worked. And also because of the nature of their work, because they were, a lot of times they were spending time on the street, they were talking to the same people day in and day out. They were developing relationships with the community that other service providers just didn't have the capacity to build those same relationships. So because of that, in a sense, advantageous position that they were in, they were able to better help the community of people who use drugs that they came into contact with. So that was a very interesting finding, and it leads me on to the fourth and last role that we found, which is pretty similar in that it also takes into account police officers' role as helpers, but they also had to fulfill a role in which they were health responders. So in some cases, police officers had to respond to overdose calls. And this was a very frustrating situation for them. And it caused a lot of, and it was very upsetting too, because they were building a lot of these relationships through their helper role, having to revive people that often really took a toll on some of them. And even in places and in cities where police officers were not required to respond to overdose calls anymore, they were still attending some of these calls regardless, as to help other first responders who were requiring public safety. So they were still playing a role in providing public health to that community, even when most of them expressed feeling uncomfortable with doing so because they didn't feel like they had the necessary training to be providing that service. So our second theme, we wanted to highlight that a lot of the police officers that we talked to also proposed solutions to addressing the strain and the frustration that they felt by having such competing and sometimes conflicting demands from the different roles that they played. So a lot of them talked about training, and they expressed wanting to learn more about how to respond to especially mental health crises. They didn't feel like they had the necessary knowledge or training, and when they did, it was usually because they had learned it on the job as they were doing it, as opposed to having received any formal training on it. A lot of them also talked about collaboration and communication. So they recognize the need for communicating more effectively with other healthcare and social service providers. Like I said, a lot of them felt like a lot of the situations that they were thrown into, a lot of the roles that they had to play were out of the, they didn't really have the tools to address those issues, and they wanted to collaborate with other social service providers like social workers, mental health nurses, doctors. And finally, some officers also talked about redefining the role of police entirely. There was one officer who particularly talked about having hiring new police officers in a new role, and hiring police officers who were previously trained as mental health nurses or as a nurse or a social worker, and hiring them and training them as police officers on top of that, so that they would have that extra knowledge and they would be able to tackle situations like the ones that they're currently put in, where they feel like they're overwhelmed. And some of them also talked about incorporating corresponding teams, so responding to mental health crises or overdoses along with a social worker or a nurse or a doctor, or ideally a team of all of these professionals at once, In some places, these approaches were already being used or had been used in the past. And everyone expressed that they were pretty positive about the outcome of using corresponding teams. So they felt like this could be a solution. But in conclusion, it was pretty evident that there is a high demand for more collaborative work between police and all of these other service providers. And this would be beneficial not only for officers who are faced with all of these frustrating situations that I just mentioned, but also for the community of people who use drugs that they interact with, because they, and the community at large, right? Because our expectations of police also define how happy we are with the job that they're doing. And if it's not clear what their expectations are and what their roles are, we may also not be expecting the right things from police. So it could be beneficial for everyone, not just for police officers straining. And finally, we think that police roles should take into account the local context of where police are performing these roles, because a police officer in a big city is not going to have the same demands from a police officer who's working perhaps in a small town where there aren't any harm reduction services. So they may be filling that helper role a lot more than someone in a big city. And there isn't really a one size fits all solution to all of these issues. So that's very quickly what we found. And I'm happy to talk about this further. That's my email on the screen. Feel free to shoot me an email as well. Thanks.
Thank you, Naomi. We're going to go to Maria and her presentation, but I wanted to let our attendees know, because we're having trouble with Ashley Stewart's presentation and getting it loaded and sharing the screen properly. Again, our apologies. It'll be on the WOA app, so you'll be able to view it. We'll straighten out all those technical issues and we'll get it going for everybody. So Maria, you wanted to share your screen, is that correct?
Yes, please.
Okay, I think Richard's going to help us with that down at the bottom, unless you can just click on that share screen green arrow. There we go.
She's got it now. She's good to go.
Can you all see that so far? Are you seeing my slide deck?
Yes, we're going. Yeah, we're good.
Perfect. Great. So Naomi, thank you so much. That was such a great setup. Well done to the organizers, because our topics and our presentations are quite interconnected and related. So my name's Maria Leggio, and I'm an associate professor in the School of Social Work at York University. My plan for today is really to present some outcomes of a pilot study that I conducted. This pilot is actually part of a larger study that's looking at the experiences that children and youth involved with the psychiatric system have of crisis and distress, and in particular their experiences of accessing and using mental health services. And under the umbrella of mental health services is police support for crisis mental health intervention. So the topic today is really focused on that. I'll be presenting a narrative study, so the outcomes of a narrative study. The study consisted of 13 semi-structured one-to-one interviews conducted with 6 child and youth mental health practitioners and 7 caregivers with a child between the ages of 12 and 24. Having said that, most of the caregivers that came forward, their children were between the ages of 14 and 17 and had different kinds of histories of involvement with the child and youth mental health system, as well as the police service for mental health support. There were 2 main categories of themes that emerged, and I'll be presenting those themes today. So I'm just going to move through my slide deck a little bit. So the issue of policing in child and youth mental health is an under-researched topic. We have some research and emerging research that continues to be produced around the experiences of adults. So adults' experiences of accessing and using mental health services, and then their encounters with police and policing. I actually wanted to start off with this quote from a young man that I had interviewed. He's 13 years old. This actually comes out of some stigma research that I conducted But I wanted to start with Tim and Tim's experience because I really think that it sets the tone for understanding the two themes that emerged from the small research pilot study. And so Tim was describing an incident where the police had to respond to the family to a 911 call. And what he describes is, and I'll just read the quote. So Tim, 13 years old, describes the night that the police responded to escort his brother, 15 years old, to the hospital. And Tim says that in that night that he, my brother, 15 years old, went to the hospital for an assessment because he was threatening to kill himself. The police came and took him away in handcuffs to the hospital. And I was bawling my eyes out, and it was like insane. After that night, honestly, all I wanted to do just to get it off my head was talk about it. I just wanted to talk, like just get it away, like how my brother went there, and just recalling the night, just to try and, like, you know, when you just are saying a word, you say it so much that you forget the meaning of it. I tried to talk about it, just so that I could get it out of my head, like just the picture of him being taken away in handcuffs. I was just trying to get that out of my mind. And so as a social worker and as a social work educator, you know, Tim's experiences draws attention not only to the distressing nature of the incident, in particular experiencing his brother's mental health crisis, but also the distress of witnessing the involvement or the intervention by police. And, you know, what Tim is really describing is the intrusiveness of the imagery and his reoccurring need to sort of talk about the event as a way to cope with the images of his brother being removed in handcuffs. And all of this suggests a real trauma and a real encounter with a traumatic event, and potentially the outcome being for Tim an experience of trauma. I wanted to ground this, the pilot study to Tim's experiences, just so that we have an appreciation of the nature of the experience that we're talking, to put us back sort of in the moment as much as possible. And so I'm going to move forward a little bit so that we can get to the pilot. The pilot, the questions that the narrative study was focused around was really looking at and asking questions related to the reasons for police involvement, and then the experiences that psychiatrically distressed young people and their caregivers have with the police encounter. $65 was provided as an honorarium for caregivers and $20 for child and youth mental health practitioners. The pilot also included looking at secondary data, doing a secondary data analysis of intake service statistics and qualitative memos about police involvement at the time of accessing and using mental health services. So over a 5-year period, there was approximately 8,920 intakes completed. So children and youth and their parents accessing mental health services. Of that number, over a 5-year period, 1 in 6, so about 16% of children and youth had police involvement at the time of accessing mental health services. I shared that statistic with you because we don't, you know, this is a new statistic in the area of children's mental health. In adults' mental health, we have better numbers to get a sense of how many people who are involved, how many adults involved with the mental health system have encounters with police. So the one thing I want to draw and point out is that the number 1 in 6 is actually similar to some of the reports that are reported about adults who are involved with the mental health system and their encounters with police. So as I mentioned, I did 13 interviews, one-on-one interviews with caregivers and parents. And there were 2 themes that emerged, and I'll just go through the themes. The first theme were about the reasons and nature of police involvement. And so this theme really speaks to the reasons. And so police services were accessed primarily for mental health support to de-escalate situations involving a distressed child. Encounters were most often described as negative and associated with stigma and criminalization. When positive, the encounters with police were associated with the appropriate use of police authority, or as one parent coined it, compassionate policing. So I'm actually going to present a few quotes over the next few slides, just to give you a sense of the data. So Karen, a practitioner, she says, in terms of the reasons for why police are being accessed, in my work with clients, we've often used police for crisis situations. If a parent needs support, if a child has an aggressive presentation or difficulty regulating their emotions, and the parent is not able to work with them and it's escalating. There have been several situations where, for example, some of my kids have expressed suicidal ideation, have been out on balconies threatening to jump, and parents have had to call 911 and access police for support. So this is a typical example of some of the reasons why police are being accessed by children and youth and by parents. The next quote, Tara, who's a mom, she's really describing the nature of the experience, the nature of the encounter. And this is really marked with experiences of stigma and criminalization of the mental health issue and of the child. And so Tara says, being treated like a criminal, being handcuffed when you're having a mental health episode. I always try to think of safety of others and safety of yourself. So I try to spin, put it back and say, maybe people weren't feeling safe and that's why you were handcuffed. But when Raquel, her daughter, 17 years old, who was diagnosed with ADHD, oppositional defiant disorder, there was a query that she was also on the autism spectrum and had also experienced suicidal ideation in adolescence and had a history of police escorts to the hospital for suicide ideation. So her mom says, but then Raquel says, when I'm at the hospital, I was still handcuffed. And so other people were there, were able to stare at me. And I don't want people to think I'm a criminal because I'm there. And so those kinds of experiences, being handcuffed at the hospital, can make for not so great an experience. So that's really an example of stigma and criminalization as part of the encounter and the involvement. Rosa describes intersecting legal mandates, legal and mental health mandates. So Rosa describes, they treated him, Ron, 15 years old, with a history of ADHD, diagnosed with anxiety, and also his latest query was PTSD as a result of exposure to violence that occurred in the home. So Rosa says they treated him, Ron, 15 years old, as if he were a hardened criminal. And it seemed there was no respect. Ron broke the law, and that's not good. But the police dealings with my son, they didn't take the care. It never dawned on them that, you know, this guy's 15 years old, like what's going on with him. It wasn't like that. It was just, you're a criminal and you're going to jail, and even treated him verbally bad. It was hurtful, just hurt a lot. That these people, responding officers, they don't see that person as a life, as a human being. They see the crime and they just treat the person badly, cold, you know, just really, really cold. So these quotes are really describing the nature of the encounters with police for mental health support. When the encounters were described as positive, they were associated with the appropriate use of police authority, or what Grace, one parent, described as compassionate policing. So here's how Grace describes compassionate policing. They spoke to me initially, and then they spoke to my daughter, Carol, who's 14 years old, suffered from anxiety and trauma related to a sexual assault by an older peer. And then they brought us back together in the room. They explained to Carol that they felt there was enough evidence that he would be arrested and charged. Carol became very defensive, very guarded, and she panicked. She didn't want him to get in trouble. The responding officer really took their time, took the initiative to speak to her and to explain to her. So across the interviews with practitioners and caregivers, positive police encounters were associated with the use of their roles, mandates, and importantly, their authority to create and hold a space, both physical and emotional, that made the child and caregiver feel they were listened to, heard, understood, and ultimately respected. I'm going to go on to the next quote. Let's see what's here. I'm just also really conscious of the time. So Rosa also describes compassionate policing as an associate use, as an appropriate use of authority for countering dehumanizing practices by complicating the legal mandate. And so Rosa, as a mom, says if the police showed a little bit more compassion and understanding, it would really go a long way. The police have a lot of authority, and they're the ones that could really shift things. I'd like to see the police have more compassion when dealing with youth who commit offenses. Just step back a little bit. Don't be so quick to treat them as if they're nothing, like just a piece of wood that you just move around from here to there, like cattle, just like herding cattle. What I'd like to see that they do a little bit more delving into what might be going on inside their minds. Theme number 2 was really about the interactions between the child and youth mental health and police systems. And really, this finding really speaks to the ways that the children's mental health system is interacting with the police system, and then how those interactions are experienced by children and youth and caregivers. So the interactions between the child and youth mental health and police systems seem to exacerbate the stigmatization and criminalization of distressed children and youth, primarily in 2 ways. First, by unmet expectations. So basically, what children and youth and parents are experiencing is being shuffled between relying on police for mental health support when they're not able to access appropriate crisis mental health services. And then the crisis mental health system is then suggesting that parents call police. And so, there's a shuffling between the mental health system and the police system. The police are trying to access mental health services that either are inadequate or don't exist. And then the other is in the police charging practices on subsequent mental health calls. I'm just wondering, can someone just tell me quickly how much time I have left?
Probably just a few minutes. We have Ashley has joined us now. I'm not sure if she's able to share her presentation or not, but she might want to say a few words. I'll just, we'll go from there, but probably just a few more minutes. And Maria.
Okay, so maybe what I'll do is I'll read this quote and then I'll go to my conclusions. So this is Tara, a mother who and her quote really speaks to the unmet expectations. So while police were responding to the home, I fully expected them to take her back up to the hospital for an emergency assessment for suicidal ideation and threats. Anyways, they came back out after talking to her for maximum 15 minutes. And the younger of the 2 cops said to me, well, we're just going to leave her with you because we don't think she's going to do anything. And they handed the knife back, and they handed me the knife back. And I just looked at them and I felt like saying, really? I thought when the police came that this would be the answer. Why wouldn't they take her up to the hospital? I mean, this kid has threatened to hurt herself. She's threatened to hurt other people in the home. The next couple of quotes just really are about the mental health system trying to access police services to get emergency mental health support for the kids. And it just really posed a real interesting contradiction because these 2 practitioners are actually the mental health workers that families are turning to for support. And so these are the workers that are then accessing police services. So there's a real disconnect between what's happening between the mental health system and police services. So I'll just go to my conclusions and my implications. So really, the implications for research and practice, just distressed children and youth get caught between the mental health and the police system. We need to explore further the mental health support roles of police. Should police be the only system responsible for ensuring safety, providing escorts? And we need to really explore further the idea of compassionate policing. And then also the implication around adopting models of practice that have distressed young people supported by the mental health system. What does the child and youth mental health system need? And can parents benefit, for example, from crisis intervention training? And all of this is rooted in a commitment to really de-policing crisis responses with children and youth. So I think I'll leave it at that, and then I'll answer any questions that people might have in the Q&A time. But thank you for your time.
Thank you, Maria. That was really, in many ways, very chilling. And I'm sure there'll be lots of questions. I invite people to put questions in the Q&A or raise your hand. But we're very happy to say that Ashley Stewart has been able to join us. Still having a little problem with that video, which will be uploaded to the WOA app and you'll be able to see it. But Ashley's going to do a brief run through of what her research is and her findings. So Ashley, I'm glad you could join us.
Good.
All right. How are we
There, that's
going?
working.
Have you got me?
Yes, that's working. We have your presentation on the screen.
Excellent. And you have my presentation slides, not my presenter view.
I don't know what we have. Well, I guess we'll find out.
You can't see my notes, I mean.
Oh, no.
No, brilliant. Okay. I have no idea what time it is where everyone else is at the moment. It is very, very early for me in Australia, so I will say good morning. I'm glad that I have been able to get online this morning, so here we go. So my name is Ash. I am working as part of the Behaviours and Health Risks team at the Burnet Institute in Melbourne. And this morning or this afternoon or this evening, wherever it may be for you in the world, I will be presenting on mental health contacts. Let me just move this out of my way. Mental health contacts in the year prior to first adult imprisonment among men with a history of injecting drug use in Australia. Just firstly, I would like to acknowledge the traditional custodians of the land on which I'm presenting from today and the lands in which this study takes place in Victoria in Australia, and the traditional custodians of the land on which others may be joining from. And I would like to pay my respects to their elders past, present and emerging. As I am joining from Australia, I extend my respect to any Aboriginal and Torres Strait Islander people who are present today, and especially recognise the strength, resilience and capacity of Indigenous peoples internationally, and acknowledge the disproportionate burden that both the criminal justice involvement and alcohol and other drug systems have within some Indigenous communities. Just a couple of disclosures before I get going. So Professor Mark Stuve and Professor Paul Dietz, who are part of this project, have received some investigator-initiated funding, but this is for research unrelated to this work. So just to start off, a bit of background. So custodial populations, as we know, have significantly higher rates of mental illness compared to general populations. And recent global estimates suggest that around 14% of people in custodial settings have a history of a diagnosis of a serious mental illness. Whereas in the Australian general population, serious mental illness affects approximately only 2 to 3% of people. So among people in prison, approximately 50% of people in Australia report mental illness, 27% are prescribed medication for mental illness, and 23% report ever intentionally harming themselves. So this really illustrates the high level of mental health morbidity experienced by people in prison in Australia, which we know is consistent across international settings. It's also important to highlight that upon release from custodial settings, people with serious mental illness experience higher rates of homelessness, unemployment, substance use, and have an increased risk of self-harm and suicide. So while the occurrence of mental illness and substance use is also common among custodial populations and is associated with an even higher rates of poor post-release outcomes and increased risk of re-imprisonment compared to those without co-occurring illness. So engagement in public mental health services indicates a really high level of mental health care need, as specialist mental health services are aimed primarily at people with serious mental illness who experience high levels of psychological distress or crises. So contact with these services may provide opportunities for intervention in preventing imprisonment among this group. However, little is known about mental health contacts prior to episodes of imprisonment. So to provide a little bit of context for these specialist community mental health services in Victoria, so in the state of Victoria here, we were one of the first states in Australia to implement deinstitutionalisation of those larger mental health hospitals, replacing standalone psychiatric hospitals with mainstreamed inpatient mental health services, and invested in community-based clinical and non-clinical mental health services to provide varying levels of support and care. So these area-based clinical services include crisis assessment and treatment team that provide that really urgent community-based assessment and short-term interventions for people who are in particular mental health crises. mobile support and treatment services. So these are provided for intensive long-term support for people who have prolonged and severe mental illness. Continuing care, so that non-urgent assessment, treatment, case management and support, and acute inpatient services, so voluntary and involuntary short-term inpatient management for people who are not able to be safely managed within the community. So these clinical services also operate alongside a range of other services such as secure extended care inpatient services for medium to long-term inpatient treatment, community care treatment and rehabilitation units, and consultation and liaison psychiatry, which involves mental health support during periods of physical health morbidity. And so the services that you can see on the slide, those are the ones that we'll be focusing on today and for this study. So to address the gap in literature on mental health contact prior to imprisonment, we aim to describe the frequency and type of public mental health service contacts in the 12 months prior to first adult imprisonment within a cohort of men recruited in prison who report recent histories of injecting drug use. So data for this study come from the Prison and Transition Health Cohort Study, or PATH. So PATH is a prospective cohort study of 400 men recruited in the weeks preceding release from prison from one minimum, one medium and one maximum security prison in Victoria, Australia. Study eligibility involves self-reporting at least monthly injecting drug use in the 6 months prior to imprisonment, being at least 18 years of age, being sentenced or not on remand, and consenting to complete the baseline and up to 3 follow-up interviews. Baseline interviews occurred between September 2014 and May 2016, and these were completed a median of 39 days prior to release from custody. So we retrospectively linked PATH interview data with records from 3 administrative databases. So mental health records come from the the Victorian statewide public mental health database from 1986. Dates of adult imprisonment episodes from the Department of Justice and Community Safety from 1999, and Victoria Police arrest data come from the Law Enforcement Assistance Program, or LEAP database from 1987. So in this analysis, retrospective imprisonment data was used to determine participants' first adult imprisonment episode and the date of that episode, and public mental health contacts recorded within the year prior to that prison entry date were determined for analysis in this study. So mental health contact in 12 months prior to first adult imprisonment was that primary outcome of interest for this work. One mental health contact was allocated per individual per day to estimate contact episodes. So where 2 or more contacts were recorded for the same individual on the same day, the more severe contact type requiring the highest level of care was considered the contact type for that day. So if someone had a CAT or a crisis assessment team contact, and then they had a continuing care contact on the same day, the day was determined as a crisis assessment team contact day. So these contacts, as you can see, were grouped into 5 mutually exclusive categories of diminishing severity. And from that highest need to lowest need, these included crisis assessment and treatment team and emergency contacts, so that really high level urgent care, mobile support and treatment team services for that intensive community services for prolonged support, intake and triage services, so relating to that initial psychiatric assessment to determine the nature of concern and the level of care required for somebody, continuing care services, so that's standard non-urgent assessment treatment and support, and any other services, so primary mental health, consultation and liaison psychiatry services, which was during those periods of physical health morbidity, and hospital outpatient services, and any services that were coded as unknown within the data set.
Ashley, can I jump in for a second? You only have about 3 or 4 minutes because we have to have a hard stop at 10 minutes to the hour.
Okay, let me push through very quickly. So of the 400 PATH participants, 15% or 60 participants had a mental health contact episode within a year prior to their first adult imprisonment. The mean age at first imprisonment was 26 years. Most were born in Australia. We did have 22% who were Aboriginal and Torres Strait Islander. And I'll let you have a read of the couple of other demographics on that screen. So descriptive statistics were generated for participant characteristics, and they were disaggregated by people who did have a contact within that 12 months prior compared to people who didn't have a contact. And we compared these descriptive statistics and found no differences between the 2 groups after doing this. So some of the main points, there were 858 mental health contacts among those 60 participants within the 12 months prior. 85% or most of participants had 2 or more mental health contact episodes. 52 days was the median time between last mental health contact episode and first adult imprisonment, and 70% of the participants had at least one crisis or really high level care contact within that 12-month period. The main takeaway from this graph here is that there was a subset of the 60 men who contributed mostly to that 858 contact episodes. So I said before that most people had at least 2 contact episodes. So the median was actually 5, but it did range from 1 contact per person all the way up to 175 contacts. But as you can see, most of those contacts were made up by that subset group. You can see here that continuing care contacts were by far the most common contact type within that year prior to adult imprisonment. And then the second most common type was CAT emergency contacts, and they did account for just over a quarter of all contacts. So to round it off with some quick discussion and conclusion points. So 15% or 60 of those 400 males in the study had that contact episode within that 12 months prior to their imprisonment. Most had 2 or more contacts, and these were most commonly for that non-urgent care, which is consistent with this level of care, typically accounting for the largest component of community-based mental health services in the state of Victoria. At the start of the presentation, I discussed how about 50% of people in prison report a mental illness. However, only 15% of the men in this study did have that contact prior to adult imprisonment. So it is possible that other participants in this study required but did not receive mental health care during this time, which may suggest a potential area of unmet need. We do, though, understand that mental illness typically presents episodically. So if we were to explore mental health contacts prior to subsequent imprisonments, we may find more men in this study with records of public mental health contact prior to entry. Just to finish off as well, most of the participants did have at least one of those CAT emergency contacts or really high level contacts, which indicates a really heightened period of psychological instability for many of the men in this study prior to entering custodial settings. These contacts do provide crucial opportunities to intervene and prevent entry into secure custodial settings. And this is particularly important for people who have that co-occurring serious mental illness and substance use. And finally, some further research is required to identify some evidence-based diversionary strategies and resources required, including mental health screening tools and trained personnel required to be able to divert people with the highest need from these settings. So, obviously, just a couple of acknowledgements. The past study participants, first and foremost, are just the ones that I'll highlight today. Without them, we obviously would not be able to do
leave them there while we chat for 1 minute. We're going to be cut off and we're going to lose our access here in 1 minute, but I wanted to invite participants. I know that I have lots of questions. I can see lots of things that are related amongst our presenters. So I'm going to invite everybody to put questions in the WOA app that's connected to the chat function for this session. And if our presenters would be so kind as to then check them and answer them, there's lots of connections here between what we heard about drug users in Canada and how the police feel about it and harm reduction. We heard about traumatic experiences with policing in for youth, for young people, and we heard about people who are in prison who have a history of intravenous drug use in Australia, and we can see lots of connections. I, for one, can't wait to chat with you about the fact that many of the folks have been expelled from school, like Ashley noted, and the young people and how it traumatizes them, if that was something that leads to the school to prison pipeline as it is known. And I'm also really interested in the harm reduction aspect of how the police who are working in Naomi's study see it. So I know our participants will have lots of questions as well. Please go to the chat function, and we're so glad you could join us today. And I want to thank Ashley and Maria and Naomi for joining us and presenting, and for Richard for helping us through our technical difficulties. So thank you all.
That was excellent. Thanks all. Take care.
Bye, everyone.